So, if the patient continues to improve to the point we think we might be able to evaluate to remove the patient from the ventilator, take the endotracheal tube out because their lungs have gotten to the point where they can breathe on their own, there's a couple questions that we have to be able to ask. Number one, did you fix the primary problem for which they got intubated for? The second question is, are the lungs okay? Now, this is the one that has the most evidence, the application of physiologic principles, and putting the vent mode into what's called an SBT or CPAP trial. And then the third question is do they need the artificial airway protection that the ET tube is providing? Sometimes we have patients just needing the ET tube, not the ventilator, until they wake up. So those are the three questions that we're talking about. Once again, did you fix the primary problem for which they got intubated for? Are the lungs okay for gas exchange, oxygenation, and ventilation? And do they need an artificial airway to protect their airway? And what we do in a spontaneous breathing trial is we try to take the ventilator away from the equation. We put the mode into a pressure support mode and bring it down to where we give no additional pressure support, and all we're doing is allowing a CPAP trial, or having a background pressure of about 5 centimeters of water pressure. That's really fancy terminology for saying what we're trying to do is just overcome the resistance of the endotracheal tube, because you've turned somebody's trachea from this into something maybe more like this on the inside of an ET tube. So there's more resistance there. So if we put them in a very, very minimal mode or a CPAP trial, that's called the spontaneous breathing trial, and we can do that for about 30 minutes. Now, when we take a look at this, we've seen some studies that show a respiratory therapist driven protocol can really help the situation out. And they can go around the unit and see, is the patient's respiratory rate okay? Is tidal volumes reasonable? Is the FiO2 okay? Are they on too much PEEP, right? And if you've got a respiratory rate, ideally below 20, tidal volumes are reasonable, maybe above 400 per breath. FiO2 is 40% or less, and PEEP is around 5. That would be kind of minimal settings that we could at least trial it. Now, there's a couple of ways that we can take a look at these numbers. Maybe there's a reason we go up to 8 or even 10 for PEEP. But these are sort of some reasonable numbers to think about. Okay, if I'm dealing with this, and their minute ventilation is perhaps in the single digits, and well less than 10 liters per minute, and FiO2 is at 40% or below, then that's pretty reasonable. 5 liters nasal cannula is going to be about equivalent to 40%, so we don't want to be extubating somebody higher than 5 liters. They're probably requiring too much oxygen, and we don't want somebody on too much PEEP if they're requiring PEEP, because the PEEP is applied by the ventilator. So the RT can go through and do a wean screen, and if they pass this, they can put the patient into an SBT for about 30 minutes. We can obtain an arterial blood gas at the end of that, and we can take a look at some numbers. And the most important number that we look at is the frequency to tidal volume ratio. This is also called the RSVI, and it's the respiratory rate divided by the tidal volume as a decibel. So we talked about some normals earlier. If you guys are breathing about 10 times per minute and you're breathing about half a liter per breath, that is an F to VT ratio of 20. An F to VT ratio greater than 105 has some predictive success at extubation failure. So I'm not saying less than 105, everybody's going to pass no problem. It's just greater than 105 is pretty much a hard stop and saying they got a high enough likelihood of failure, we shouldn't proceed to extubation. So once again, going through our 3 questions, did you fix the primary problem they got intubated for? Number 2, are the lungs okay for exchange? This is the major question that we're trying to answer for this one by putting them on an SBT that was an RT-driven protocol based on a wean screen. And then we can take a look at a blood gas to make sure they're not really wacky on those numbers. And then our third question is, are they okay to remove the artificial airway? If somebody's not coughing or protecting their airway, we might need to keep it in until the patient is awakened. But this would be the process of what would happen for a spontaneous breathing trial.